Tonight we're going to be talking about the cost of cancer, and we have some really excellent panelists who we will introduce in just a moment. And if we can just show the series at large, there we go. Next Wednesday will be our final session in the series. And we have a really dynamic session that is put on by our team of registered dietitians who are going to show us how to eat healthy, even on a budget. And I believe that they've done like a little bit of like a video tour of grocery stores and have partnered with some of the local grocery stores to show us how we can eat healthfully and not break the bank. So again, we're really excited to have all of you with us. I think that it looks like we're probably reaching a critical mass here. So before we start, there's two things that I wanted to share with this group in particular. And Rachel Greenup, maybe I'll have you share your opportunity with the attendees first, if that's okay, and then I'll share my flyer after yours.
Sure. So I'm just going to share my flyer quickly. Welcome, everyone. My name is Rachel Greenup. I'm the chief of breast surgery at Yale. I've been here just over a year, and I'm thrilled to join this community. I wanted to take the opportunity to introduce a study that both myself and Dr. Kubchadandi, who's a current scholar in the School of Public Health for the National Clinician Scholars Program, we are launching really to understand and characterize the lived experiences of women after breast cancer who had mastectomy without reconstruction, and to better understand how women ended up without reconstruction, and specifically better understand how life without a breast looks based on race, ethnicity, culture, and community. So you can see my profile link is in the chat. My email is rachel.greenup@yale.edu, which will be posted at the end of my talk. And if anyone is interested in participating in a 1-hour compensated interview, we would love to hear your story.
Thank you, Rachel. Along a similar lines, we are looking for survivors and patients who have gone through Smilow and received care at Smilow. Our colleague, Dr. Jennifer Kilkis, runs our psycho-oncology program, and she is looking for volunteers to discuss barriers to care in the oncology program. So they are hoping to learn more about the experience of patients who were diagnosed and treated for cancer at Smilow. There is a brief survey that they are trying to collect. I'm gonna blow this up. I don't know how big this translates on the screen. So there's a QR code that you can scan right now if you're compelled, and we could probably do it later. And then there's also a phone number if you wanted to learn more. It's there on the flyer, and we can also post this flyer, the link to this flyer at the end of the session. Okay, so now to our main event. Welcome to tonight's Smilow Shares. We are talking about the cost of cancer. A few words about this session. You know, when we got together as a large survivorship network, this was one of the first topics to come up. I think the burden of financial cost comes out in many different ways. And you in the audience are the lived experts. And tonight we have a panel of experts who work in this sphere in different ways. So I'm gonna go around the horn here and have them introduce themselves, and then they're each gonna speak for about 10 minutes, and we'll have a lot of time for questions at the end. If you're attending, just so you know, you can only see us. You won't, it's not a regular Zoom meeting, it's like a town hall format. So you can just chat your questions into us and we will take them when we're finished. And hello to all my friends out there. I see a lot of familiar names on the list. So let's go in order of presentation with introductions first, and then we'll swing back for the actual talk. So Rachel, if you want to say a few more words, welcome.
Thank you. So I'm a breast cancer surgeon, native of Milwaukee, Wisconsin, trained there for med school and residency, did fellowship in Boston, and was faculty at Duke for almost a decade before I joined Yale a year ago. I'm also a health services research, and my area of interest is the burden of care for patients undergoing treatment for cancer. And within that definition of burden, I think about financial toxicity, employment disruption, impact on family and quality of life. So thank you for having me.
Thank you for being here. Emily Rock.
Hi, nice to see everyone virtually. My name is Emily Rock. I'm a lawyer with the Medical Legal Partnership, and we work with medical providers to help address patients' unmet civil legal needs. And as you all probably know, there are a lot of issues that aren't strictly health related that either are impacted by your health or vice versa. So I'll talk more about what we do, but it's been a wonderful chance for me to get to know some of the patients at Smilow. I've been in this position for almost a year, and I love it. So thanks for having me.
Thanks for being here. Lauren Coletta.
Yes, hi. Hi, my name is Lauren Coletta. I just recently started with Yale about 6 or 7 months ago. I work with the Division of Pharmacy as one of their medication assistance program coordinators. What we do is we work with the oncology department, and we try to help patients who have either no insurance or are underinsured find coverage for their medications. So I've been doing that probably now for over 10 years. Before this, I was at Hartford Hospital doing it. So it's a very fulfilling position for me.
Well, we're happy to have you with us, Lauren. Thank you.
Thank you.
And last but not least, Gary Soffer.
Hi, everybody. I'm Gary Soffer. I help to run the integrative medicine program at Yale. I've been here for about 4 years now. If you don't know what integrative medicine is, you know, some people think about it as complementary alternative medicine, but really we like to think about it as what's going to keep you well, what's going to keep you healthy, and how are we going to change this journey that is your illness. Those are the things that we're focusing on. We'll talk a little bit about it at the end. Besides that, I'm a father of 2, and I only say that because I've got 2 loud boys jumping and screaming upstairs. So if you hear them while I'm talking, just smile and laugh, because I'm smiling and laughing.
I'm in the same boat, Gary.
Yeah, we all have my 4-year-old's on my phone, which will keep her quiet for the next 50 minutes or so. So we're all in it together. Well, let's start our lineup here with Dr. Greenup hitting us off, and let's have you take it away, Rachel.
All right, I'm going to share my slides here. Can you all see that? Okay, so I'm going to focus on financial toxicity, which is also known as patient costs for breast cancer care. In 1999, the Institute of Medicine recognized that ensuring quality cancer care needed to be a key priority for the United States. They recognized large disparities across the country, that access to care and barriers to care were a huge problem for individuals after diagnosis. And they charged the country with moving forward to improve clinical care, incorporate evidence into practice, to do a better job capturing and monitoring data, to develop quality measures that could be standardized, allowing for comparison from one health system to another. They charge us with improving access to care for our most vulnerable patients, and as part of that, to improve the ability to afford care. And then lastly, when we could no longer cure our patients, to provide better end-of-life care. About 40% of US families still report financial distress related to medical treatment. And this is not only cancer specific data, but if you look at what pushes people from financial security into financial distress, it tends to be a major medical diagnosis, specifically of the income earner within a household. These data in the graph are from the Centers for American Progress, published in 2017, and I recognize that it's a little old, but it's really powerful data in that you can see that healthcare spending has grown much faster than the rest of the economy in recent decades. So between 1960 and 2010, expenditures for healthcare have grown over 800%. But wages have only grown 16%. So it's not surprising that we are struggling to afford cancer care. We also 20 million increased as a result of COVID-19, that there are significant socioeconomic disparities with Latinos and Blacks being disproportionately at risk. There's high cost sharing. So when healthcare got more expensive, payers or insurance companies shifted much of healthcare costs to individuals, and that this resulted in unaffordable care. And lastly, there's been a rise in high deductible insurance plans, specifically for many of our younger patients, where you pay less on a regular basis, but the deductible at diagnosis is very high, and we have seen that this results in delays in or omission of preventive care. In 2013, my friend, mentor, and colleague Yusuf Soffer at Duke introduced the term financial toxicity into the literature. And financial toxicity really, for the first time, recognized that the costs of cancer care were a meaningful side effect of our treatment. Financial toxicity describes the mental and emotional stress related to the unaffordable costs of cancer treatment. And the National Cancer Institute has formally recognized this burden. This is a conceptual framework that researchers use to outline how costs of cancer care impact downstream outcomes. And you can see here, not surprisingly, that pre-illness health, assets, debt, and income, as it impacts illness or injury, as it impacts medical insurance, treatment costs, both medical costs, so these are paying for your actual health care, and non-medical costs, which I'll get to in a bit, but these are things like transportation, lodging, costs of wigs and prostheses, all can contribute to downstream financial strain and distress, which can unfortunately result in formal bankruptcy and impact health outcomes. When we talk about financial costs and care burden, I think of this in three categories. So direct healthcare payments includes what patients and their families actually pay for medical treatment. Indirect costs describe lost productivity. So this is employment disruption or job loss and lost wages in terms of taking time for treatment. And then lastly, hidden costs, which are really poorly characterized. So travel, lodging, childcare, having family members move cross country to support you so you can go to your chemo appointments. Financial toxicity has been shown to be associated with many, many things. 40% of insured patients report difficulty affording deductibles. Up to 25% have used most of their savings to pay for care. We know that financial burden is associated with poor mental and physical health. Blacks are disproportionately at risk of financial harm. We know that individuals in private insurance or employer-based insurance who are non-Medicare eligible are at greater risk. And there's a twofold increased risk of bankruptcy after cancer. This is a beautiful study done by my friend and colleague, Stephanie Wheeler from the University of North Carolina, in which she leveraged the Carolina breast cancer study to compare Black and white women about their experiences with financial hardship after breast cancer. And she notably enrolled an equal proportion of women who were Black and white. So it was a very well-balanced study, and it included over 2,500 participants. And across all domains of financial hardship, Black women were at greater risk when compared to whites. So Black women were more likely to report any negative financial impact related to their breast cancer diagnosis. They were more likely to see a decrease in their household income. They were more likely to have financial and transportation barriers to care, to lose their jobs, and to lose their insurance. We also know that financial hardship impacts quality of life and is associated with a poor quality of life. And this is a study done in 2015 using the Medical Expenditure Survey, which is a national survey asking cancer survivors about their experiences with care. And as the number of financial problems increased, the physical and mental quality of life scores decreased. And up to 1/3 of cancer survivors reported that financial burden impacted their quality of life. Similarly, we know in the metastatic population that financial hardship impacts treatment non-adherence or refusal. And this was, again, a study out of the University of North Carolina showing that Black women were far more likely to stop or refuse treatment when it became unaffordable. White women were more likely to do things such as skipping vacation, tapping into savings, borrowing from family or friends, but women of color were far more likely to forego necessary and or recommended therapies. We also know that financial hardship is associated with employment disruption, not surprisingly, but again, in the same cohort of metastatic breast cancer patients, about 62% ultimately stopped working, and this was disproportionately seen in Black women. White women were more likely to retire or take paid leave, but women of color were more likely to stop altogether. So prior to 2016, the cancer community recognized that financial toxicity was a problem and that it was a quality of life problem. But data from Scott Ramsey's group demonstrated that it impacted survival and cancer outcomes. Dr. Ramsey from Fred Hutch at University of Washington in Seattle compared statewide SEER registry data. So this is a population-based registry, and this is important in that includes a very diverse cohort of women with breast cancer. And he compared it to statewide bankruptcy claims data. And what he found was that bankruptcy was a risk factor for early mortality after breast cancer diagnosis. So women with breast cancer who declared bankruptcy were 1.5 times greater risk of death, and that this existed across all stages and across years from diagnosis. And this really caught the attention of the oncology community, recognizing that we needed to intervene. So much of my work has looked at helping women think about costs and think about the trade-offs of costs as they're making preference-sensitive decisions. So when I meet as a surgeon, women and their families around the time of diagnosis, we talk a lot about recovery time, risk of recurrence, peace of mind, side effects and complications, need for surveillance and appearance, but we don't really talk about what it will cost them in terms of monetary out-of-pocket expenditures or in terms of time off work. And we performed a survey. This survey was developed with help from patient advocates through the Alliance, which is a national oncology community. We pre-tested it, and then we partnered with 2 survivorship groups, including the Army of Women and the Sisters Network. And we had over 600 participants, generally younger and with early stage breast cancers, about 7 years from diagnosis, overwhelmingly well-insured and overwhelmingly with a higher household income than most women in the United States. And when we asked women how important costs were when making surgical decisions, only about 1/3 reported thinking about it. And not surprisingly, when women were asked what mattered most to them, opinions and advice from their medical team and fear of recurrence or survival were the things they cared about. And you can see at the bottom that costs of treatment were relatively low on their priority list. But when we subsetted out women of lower household income, so this was women who had a household income of $45,000 or less, they still cared most about what their team recommended, and they still cared most about being cancer-free. But you can see that costs of treatment rose dramatically and actually was more important to these patients than what the appearance of the breast looked like, or than even keeping the breast. 80% of women reported they wanted to know something about cost of treatment before they started therapy. 40% believe that their doctors should be thinking about this when making medical recommendations. And 35%, even among this really well-insured, relatively financially secure participant group, reported that they had somewhat to catastrophic financial burden as a result of their cancer diagnosis and treatment. Notably, we did find that women who had bilateral mastectomy were more likely than women who had lumpectomy to have employment disruption, difficulty, pain, for reduced financial hardship. Not surprisingly, but importantly, we found that 80% never talked about costs with their team. 35% said that costs were higher than they expected. The median reported out-of-pocket costs, or the average, was $4,000, but about 5% of women reported spending over $40,000 to pay for treatment. And again, higher out-of-pocket expenditures were associated with more comprehensive treatment, including more surgery, chemotherapy, and reconstruction. And that probably has something to do with having care that spans over 1 calendar year and needing to pay your deductible more than once. We then looked at the qualitative responses of these women. We allowed them to do a write-in of what their experience was like, and they described a financial arc where in the beginning they were really uncertain what it was going to cost them, and then the bills came and they paid them, or they went into debt. Again, care extending beyond 1 calendar year resulted in multiple high deductible payments. A lot of women talked about borrowing, fundraising, or leaning on financial assistance programs. There was great report, almost 70% of participants saying they had difficulty navigating their insurance and the health system. Lots of women talking about either losing their jobs or being held back from career promotion. There was an unexpectedness of costs. And in a really heartwarming way, many of the women, not surprising to me knowing our breast cancer population, talked about their awareness that others had greater needs and that they couldn't imagine what women went through if they didn't have insurance or didn't have any funds. But I think some of the strongest statements were from the voices of patients themselves. One woman said 15 years of savings was completely depleted in 24 months. I never in my life thought I would spend the entire thing on paying for cancer bills. One said, I lost my job when I began treatment and have been unemployed or underemployed ever since. One woman talked about the hidden costs: food, gas, transportation, parking, mastectomy, bras, non-healing infection. The non-medical costs were so high. And then there was a lack of cost transparency. So none of my docs, who I all considered very good in other ways, ever mentioned costs. And I found the unexpected costs to be most difficult to budget for. Without warning, it was tough every time. In conclusion, personal and population spending have been proposed as key components to measuring high quality healthcare, and I personally will spend my career making sure we make progress in moving the needle. We know that financial costs and burden of care matter to our cancer patients, not only as a quality of life issue, but also in terms of making sure they have the best outcomes and effective interventions are needed. I want to thank my mentors, my teams, the women that participated in my research, and I'd be happy to take any questions at the end. Here's my email if anyone wants to talk about this further or is interested in our participating in our Life After Mastectomy study. Thank you.
Oh, thank you, Rachel. That was amazing and so informative. I just ordered a CAT scan today for a patient whose insurance rolls over July 1. And, you know, should we or shouldn't we would wait normally until the next visit, but we're going forward because of that financial issue. So I appreciate all that you said. Next up is Emily Rock. Emily, take it away.
Yeah. All right, let me share my screen here. Everyone see that?
Yep, looks good.
So as I mentioned, I'm with the Medical Legal Partnership. We're a collaboration with Yale Law School and Yale New Haven Hospital. We are lawyers and law students who work with patients, and we work with a number of different patient populations, including veterans, folks who are uninsured, geriatric patients, palliative care patients, and oncology is one of our latest projects. So we just started last August. Right now we're working with breast cancer patients. Just because of capacity, we aren't able to take all patients, but if you're participating tonight and you're interested, you can certainly reach out to me, even if you have a different type of cancer. And if I can't help, we can try to refer you to someone who can. So my contact information is there, and feel free to call or email, and I'll tell you some more about what kinds of things we do. So first, what is a medical legal partnership? So it's an interdisciplinary program that allows us to work alongside medical providers to meet legal needs. And medical legal partnerships have really grown over the last 10 or 20 years. So they're now over 400 different medical legal partnerships across the country, affiliated with different universities and nonprofits. And studies have shown that these partnerships help improve access to housing and utility needs, reduce stress, improve access to personal and family needs, and improve access to education and employment needs. So we really have been able to see concrete evidence of how these programs are able to help patients. In terms of our oncology medical legal partnership, I'll run through some of the topics that we usually deal with. And I'll say also that we aren't limited to any particular, we're not like a housing clinic or any specific legal issue. Everything we do is civil, so we can't help with criminal issues, and there are a few other kind of areas that aren't in our wheelhouse, but in general, anyone with any kind of legal issue, we try to either help them ourselves or refer them to someone who can. So housing is one of the issues that comes up frequently. And one example, one of my earliest clients was a patient who had been out of work because of both COVID and her ongoing treatments. She fell behind on her rent and received an eviction notice and didn't have the funds to pay her rent. And we were able to help her apply for a rent relief program that allowed her to stay in her home while she continued treatment. So that was a really exciting success story for us. We also see a lot of people with employment issues. As Rachel touched on, cancer, of course, can cause disruptions to employment or people to lose their jobs. So we had another patient who took leave under the Family Medical Leave Act, leave that she was entitled to as a teacher. And while she was on leave, she was fired from her job. And the administrator who fired her made comments about, we need someone who's going to be here, and we don't know how long your treatment's going to last. So it was pretty explicit. So that's another case where we were able to intervene and help. And one of the wonderful things about a medical legal partnership is often we're able to intervene earlier than most lawyers get involved in someone's case. So before it becomes a lawsuit or something that can be really high conflict and lasts a long time, kind of are able to work upstream, and it's almost like preventive legal care. So in this instance, we're able to write a strongly worded letter citing case law and explaining why you cannot fire someone due to their medical treatment while they're on FMLA leave, and she was able to get her job back. So another topic that comes up quite often is different kinds of public benefits. So anything from someone who just doesn't know what kind of benefits they might be eligible for, whether it's Social Security, disability insurance, state benefit programs, or something else. And then people who are applying for programs and need help with the applications, or have applied on their own and then get a denial. In the case of Social Security disability, it's very common that an initial denial is made, and then on appeal, especially for someone who has legal counsel, they may be able to get that decision reversed. And it's not a requirement that you have a lawyer in that situation, but it certainly helps, and the stats show that people are much more likely to prevail with the assistance. Unsurprisingly. Another topic that has come up increasingly is estate and advanced care planning. So we've helped people with drafting wills and drafting powers of attorney so that someone they trust can deal with financial matters for them. Other documents include assigning someone to be your healthcare representative and make decisions if you're unable to. So that's another area that we've been able to assist people pretty frequently. And in addition to the direct patient care, we also do trainings for medical providers on legal issues that affect their patients, and we participate in structural advocacy, such as advocating for legislation that will help patients. So this year we were able to submit testimony and testify equitable bills that the Connecticut legislature was considering that would benefit patients, and we were able to work with one of our medical partners to submit testimony as well. So that's medical legal partnership in a nutshell. And here's my info again. So feel free to write down my email address, phone number. And as I said, while we generally work just with breast cancer patients, if you have a different type of cancer, you have a legal question, please reach out and we will help you as best we can. And if you have an issue that's wasn't listed or I didn't talk about, that's fine. We are happy to speak with people, whatever the issue it may be. So thank you all.
Thank you, Emily. And ideally, this program grows to encompass all legal issues that cancer patients at Smilow face. So thank you so much. And I do hope that the audience will take you up on that offer to run any question, even if they're not breast cancer patients, by them. And I think, ultimately, there are programs that are being built in place to help with some of these for more patients. So, thank you. And now we'll move on to Lauren Coletta from our medication assistance program.
Sure. Okay. Okay. Can everyone see this?
Yeah, it looks good.
Okay. As I said earlier, my name is Lauren Coletta, and I work with the Division of Pharmacy here at the Smilow Cancer Hospital. I'm a MAP coordinator, which is a medication assistance program coordinator. And in this presentation, I just wanted to kind of let you know what we do here and how the cost of cancer and the medication assistance program can help patients overcome their financial barriers. So what is MAP? MAP is an acronym for the Medication Assistance Program here at Smilow Cancer Center. And the MAP program is managed through the pharmacy department. The program assists uninsured and underinsured patients to afford their medications. It also supports the institution by potential write-offs by using our copay assistance programs. We as an institution understand that the US's #1 factor of bankruptcy is medical debt. Our MAP program helps to assist with mitigating and financial burdens and toxicity. Some of MAP's objectives are to reduce patient financial hardship. In the next slide, we can discuss that more. There's more information. Minimize the potential of institution write-offs. We minimize the potential of institution write-offs, and this is done by getting patients to be able to pay their copays. Our coordinators do this by helping them get enrolled and approved into copay assistance programs if they have out-of-pockets or high deductibles. Next is increased patient adherence. Increasing patient adherence is done by minimizing admissions into the hospital. We need to make sure patients get their medications so that they can start and continue on their treatments. Lastly, utilize prescriber preferred courses of therapy. Utilize prescribers' courses of therapy. We want to make sure that the patient gets the treatment they deserve, even if they are uninsured, underinsured, or their insurance refuses to pay for their therapy. What services does MAP provide for patients? MAP can provide services for patients in many different ways. We do this by drug replacement, copay assistance, and foundation grant assistance. The drug replacement program is for outpatient oral, self-injectable, and intravenous medications for under or uninsured patients. The copay assistance is for commercially insured patients with large out-of-pockets, responsibility, and for patients whose treatments are not being covered. Foundation grant assistance is for patients with commercial or federally funded insurance plan, such as Medicare. How can providers and patients access MAP services? One of the ways that the MAP coordinators can be contacted are from patient referral forms found at the nurses' stations. Pharmacists on the floor have these referral forms as well, and also social workers. We can be contacted by phone, Epic, in-basket, Skype, and link listed on the screen in front of you. We receive our patients through the Viber that you see in front, which is our online platform service. The server will match patients to different programs depending on which insurance that they have, the medications that they're currently taking, and also their diagnosis. Who do we service and who is part of the MAP infusion team? We service all of Connecticut, parts of Rhode Island, and our team consists of 7 different coordinators who handle Smilow Cancer Hospital, Smilow Cancer Care Centers, and also clinics. We also have a MAP team who works at our Yale New Haven outpatient pharmacy. The outpatient pharmacy is located in Hamden, Connecticut, and the phone number is listed on the slide in front of you if you ever need any other information. If you have any questions, please feel free to ask me more at the end of each presentation.
Thank you, Lauren. It was so great. I think we will have a question for you. We'll save it for after Gary's, but that was so great. And the pharmacy is really just one of the best departments, I think, in the whole medical school. So we're so grateful for the care that you all provide.
Thank you.
All right, we have one last presentation before we open it up for discussion. Dr. Soffer. What a lovely set of talks we've had so far. I really appreciate everyone, and we have such good turnout for tonight's session.
This is the wrong presentation. Nobody cares about early effective probiotic use.
I wouldn't put it past this crowd. They might want to know about that too, but we'll stick to the topic.
Let me try that again. All right. How's that looking?
Great.
Better? Okay. So I think this talk is going to be a little bit of a departure from the prior talks, but I think it should be fun and interesting. I just want to start out by giving Smilow and especially Dr. Sanft a shout out. I've been working here for 4 years now as a physician, but this year I got to experience indirectly through a family member what it's like to be a patient at Smilow. And what an incredible group that you all have the ability to share this journey with, who can support you and love you and take care of you. I feel really, really fortunate to have had that experience. So we're going to talk about the cost of cancer supplements and natural products. And I'm going to start off with a disclaimer because we're going to talk about it sort of from a negative standpoint, but we live in a period of absolutism. This is good and this is bad. This is right. This is wrong. Natural products definitely have a role in your care and patient care. And certainly some of them can be helpful, but it's important to understand they're not risk-free, and natural doesn't necessarily mean safe. I often remind my patients that you should remember that poison ivy is also natural. So we want to be smart and safe about our use. But what are supplements and natural products? So this is really a category of complementary or alternative or integrative medicine. Other categories include things like mind-body medicine, energy healing, spirituality, and other pieces. But this is one specific piece, and it includes things like medicinal plants or herbs, vitamins, and dietary supplements like enzymes or probiotics. And of course, some of this also comes up in conventional medicine, right? Like vitamin D, or even sometimes you'll get prescribed probiotics. And when I think about cost in this field, I really tend to think about it in 4 domains. And we're going to go through each of those domains. So the first domain that I think about is financial, because there's an out-of-pocket cost. There's the health cost, and we'll talk about risks and side effects. Then there's the cost of hope, of putting your hope into something that may be a little bit disproportionate to what it may benefit you. And then there's the cost of missing out on everything else, and we'll talk about that at the end. So what are the financial costs? Total out-of-pocket costs in the United States for natural products is about $33.9 billion. So this is a massive, massive business. This obviously doesn't go through the same traditional routes of pharmaceutical or insurance companies. These are largely private companies selling these herbs and supplements over the counter. In one study looking at thyroid cancer, patients spent about $20 to $100 a month on their supplements. That's a good amount of money. And then I've seen alternative cancer treatment centers cost patients as much as $500,000, if not more. I'm often hearing stories of anywhere from tens of thousands to hundreds of thousands of dollars. So it's a pretty vast financial investment from patients, and we question if it's a worthwhile investment. But more importantly, what are the health costs? So our primary concerns are first interactions. Is this herb or supplement going to interact with medication that you're currently taking? Now, this fancy picture on the right, you don't have to understand it. You don't have to know anything, but what you have to know about is that some of these supplements and some of these herbs will go through the same metabolic pathway. They'll be metabolized through the body, through the same channels as your chemotherapy or your immunotherapy or any of your medications. And that can disrupt how that medication is absorbed in the body or how it's metabolized in the body, meaning that you can end up with more of that medication or that you can end up with less of that medication, and it can really disrupt your treatment. Then there's side effects. Certain herbs and certain supplements can cause things like bleeding, or even one really well-known side effect is something like lavender. Patients who take lavender as a supplement are increasing their estrogen levels. So one study in children showed that children who were using topical lavender developed early breast development. So we need to be really, really careful about what we're using and how it can impact us. And then finally, the quality of supplements. That's a really, really big issue. There's, all you have to do is walk into a CVS or a Walgreens and you can just see walls and walls of supplements. There's so many companies out there. There are tens of thousands of companies selling supplements. And the problem is there's not a lot of oversight. So just a couple of examples. They've done studies where they actually look at the supplements themselves using a DNA barcoding method. They look at the DNA of what's in the supplement itself, and they found that half of them were actually mislabeled. They found a product that had St. John's wort as the label, but it was actually senna. So senna is a laxative. That's not what you want. They've even found male virility products just to contain Viagra. So there's not a lot of oversight in these things, and there's real risk of side effects, even if you think you know what you're getting. This is an important study that came from our colleagues at Yale. And this is about alternative medicine. This isn't about integrating some supplements into the care, but by using alternative method, what they found is that going the alternative route, there's a 2.5-fold increase in the risk of death for combined breast cancer, prostate, lung, or colorectal cancer. And specifically with breast cancer, there was over a 5.5-fold increase in risk of death. So there is risk in going in these routes. Now, I do want to give a shout out to our supplements review clinic. This is a virtual clinic that I run with one of our pharmacists, Annette. And if you are taking lots of supplements, then we will have our pharmacist go through it and check and make sure there are no interactions or there are no potential side effects with the supplements or herbs that you're taking. So that would be part of the consultation with me. So the next thing I'm going to talk about is a little bit more elusive, but it's probably the most important of the 4 domains that I'm talking about. It's this expectation, it's this hope, and it's really, really important to set expectations. You know, the companies selling these supplements, they're not really required to have too much guidance in what they can say. So they're allowed to make structure and function claims. So they can say something like, helps maintain proper joint function, but they can't make specific statements like relieves joint pain. Now, this is very nuanced and it can be really misleading and confusing for a lot of people, and really give them some hope that may be, again, disproportionate to what the reality of that supplement might provide them. And then there's this fear of missing out on an opportunity, that just by not taking something because you read about it on the internet, you may be putting yourself at risk. And to me, the beauty of integrative medicine and the mindset at which I practice with is really less is more. The less we can intervene in the least invasive way, the better. And sometimes we have a tendency to take on this pill mentality that's very much a part of conventional medicine and apply it to integrative medicine. And for me, that's not the space, you know? So we look at the other opportunities within the field of integrative medicine to help manage your journey. And so that brings me to the 4th domain, which is the cost of missing out on everything else we have to offer. Oftentimes patients will just want to focus on herbs and supplements, but there's so much more that you could be doing to contributing to your care that integrative medicine has to offer. And so here at Yale, we offer Reiki and massage, and we have yoga classes and meditation classes, and you can come see me as a consultation. And, you know, what I love so much about what we have to offer, which is to my point, is you don't miss out on any of the domains, that there's no financial expense, there's no disproportionate hope, and you're not missing out on anything. And there's really no side effects. So if you do want a consultation, our phone number is above. If you want to be added to our email list, we have this wonderful email list that goes out once a week. Reach out to us or visit our resource page, which you can Google. It's the Integrative Medicine resource page. And so I thought, since it's been a long evening, and we would do just a little short practice together. This is a really nice exercise. It's called box breathing. It comes from the yoga tradition, something called pranayama breathing, but it's really basic. And all you have to remember is the number 4, and that's it. And what we're gonna do is we're gonna inhale for 4 seconds, hold this for 4 seconds, exhale for 4 seconds, and again, hold it for 4 seconds. We're going to do that 4 times. So everybody get in a comfortable position, put your feet on the floor, put your hands on your lap, and close your eyes, and just breathe naturally for a couple of seconds. And we're going to begin. Inhale, 2, 3, 4, hold, 2, 3, 4, exhale, 2, 3, 4, hold, 2, 3, 4, inhale, 2, 3, 4, hold, 2, 3, 4, exhale, 2, 3, 4, hold, 2, 3, 4, inhale, 2, 3, 4, hold, 2, 3, 4, exhale, 2, 3, 4, hold, 2, 3, 4, inhale, 2, 3, 4, hold, 2, 3, 4, exhale, 2, 3, 4, hold, 2, 3, 4. And just go back to your normal pattern of breathing. And wiggle your fingers and your toes and open your eyes when you're ready. And that's just a quick, easy exercise that you can use whenever you want. So thank you all so much again. Thank you for your attention. And I'm happy to answer any questions.
Wow. I think you just like refreshed all the panelists here. So thank you for that, Gary. And I hope our participants enjoyed this too. We have just a few minutes left for questions. And, you know, I think this has been a really diverse group, probably our most diverse panel so far. So I have a question for each of you as other people put in any thoughts. You know, Rachel, should we as physicians be talking to our patients about the cost of care?
Yeah, it's very controversial. I think that many, based on my data and that of others, there's many physicians don't know where to start. They feel really ill-equipped and ill-prepared to have accurate and knowledgeable discussions with patients. And they do have concerns are going to lead patients and their families astray. So I think physicians should not give misinformation. I do think physicians should work based on our close relationships with patients to destigmatize the issue of unaffordability of care. We're taught in medical school to ask patients if they smoke, if they drink alcohol, what they do for work, and who they live with. And I think we should say to patients, do you have any concerns about affording your care? And I think we should ask everybody. I have been very surprised over the years at who is, you know, a quiet millionaire and who really struggles financially. And it needs to be built into our workflow. We're also working in developing care pathways that prompts physicians to ask patients as part of the EPIC order set. And patients generally trust their treating team. And so if we can destigmatize it and let our patients and their families know that it's normal, the costs of cancer care are extraordinary. There's no shame around having difficulty and pain for care. It does not mean that we will withhold care. It does not mean that you're going to get less care. It does not mean that you don't care about your care or your life. And I think these are all themes I've heard through my work that patients should never, ever think twice about saying to their doctors, I'm worried about paying for my treatment, because we have so many resources. I mean, the work Lauren does is critical. There's data that even the difference of a $30 versus an $8 copay impacts women's ability to stay adherent to endocrine therapy after breast cancer. So we're here to help.
Thank you. Emily, I had a question, but there's a better one in the chat. How far does the Yale legal practice take someone's concerns? Is there a cost? I guess
Yeah,
I don't understand the last piece is your services insurance, but perhaps you know what that means.
I'm not sure what that means, but we do not have any cost. Everything we do is pro bono, and how far we take someone's concerns is just depends on the case. So most cases we're able to resolve kind of informally, but we have cases that have gone into litigation, and as I mentioned before, if it's something that's not in our wheelhouse or is kind of too complicated, we don't have capacity, we do try to find someone else who can work with you, whether it's a legal aid office or a private attorney. But yeah, all of our services are completely free.
Is it insurable was the question. Does that make sense to you?
Yes, I mean, I think because it's free, I think that question, I don't think there'd be a reason for insurance to be involved because we're not charging anything.
Got it. Thank you. So Lauren, you know, doctors and nurses, I've been here for 12 years. I've had other nurses and nurse practitioners working with me, and I feel like we don't always know the latest information. You spoke a little bit about where people can find out, and you talked about papers on the floor and that pharmacists have these, you know, how can we make sure that we're all current on the opportunities for medical assistance through the pharmacy?
Well, first of all, the MAP program, I've heard that a lot of people don't know how to contact the MAP program. Who is the MAP program? I've had in my Epic M basket, and just within the last few days, people have said to me, I've worked here for 15 years and I didn't even really know that there was a MAP program here to help patients find copays and free drug. Is there a way that you can let us know, or do you guys have flyers or cards? So what we have been doing, myself and some of the coordinators, is we have been going to the floors, and we've been bringing our cards, we've been bringing all different kinds of documents, and so that people know where to contact us, so that patients know where to contact us. Because now that COVID is slowly we're starting to get a little bit more lenient, we can go to the floors and talk to the patients, tell them a little bit about what we do, how we can help them. Because when you are on the phone or when you are face to face with somebody and you tell them, after all this work for the last week, I just got your medication covered for you, so your $6,000 out of pocket has just been alleviated. I've had people cry over the phone because now that's just one less thing to worry about. They can start to enjoy something as opposed to worrying about these huge out-of-pocket payments that they shouldn't be worrying about that. They should be focusing on their treatment and figuring out how they're going to get better and figuring out spending time with their family.
Yeah. I think that, and the theme of the night is, if you have a question, ask, and we will help get the answer sorted out. So we all, I think, need to be talking to our patients about these things, and then patients, inquire, and we should do everything we can to hook them up with you and Emily and get them into the resources that they need.
Yes.
Gary, there was a question here in the chat. A patient on the call takes many supplements. How does she get these reviewed for their effect on her cancer and treatment?
So the easiest way is to ask your oncologist for a referral to the integrative medicine program and ask them to specify that it's for the for the Supplements Review Clinic.
And I will just add a shameless plug that we had a dietitian who was working with Gary and Annette to tell you how you could get your supplements through food. You can actually eat specific foods that will give you the same vitamins and minerals that you're taking by supplement. She stepped away from our clinic about a year ago, and we have yet to replace her. But if there's enough people who keep asking for it, I know we'll get the positions approved. And really, just honestly, it's so important. I think the supplement industry is strong. As Gary said, it's a $1 billion industry. I know my own patients pay hundreds of dollars a month to take supplements that they feel are helping them. And we talk about this, about all of these things with a team that you trust, and first do no harm. So things that interact, things that cause side effects, things that make your cancer treatments less effective, we will recommend that you do not take them. Things that don't hurt you and you feel benefit you in some way, I think we've agreed that we'll work with you. Was that fair, Gary, would you say?
Yeah, no, I think that's exactly it. The first goal is it's not going to harm you or hurt you. Second goal is to see if it's going to help you, because some of them might help you. And the third goal is to work with you if we don't believe either that it's not going to harm you or it's not going to help you, but it's important to you. And what's important to you is also important to us. And we want to share that journey with you. The reason we try to sway people towards a food as medicine approach is really integrative medicine is based on thousands of years of history. And those thousands of years didn't include, herbs and veggie capsules. They really included, your grandmother's diet and your great grandmother's diet. And that's how the approach was. And so since that's where we're drawing from, that's what we should emulate. That's how we should practice.
Someone's requesting the food chart that you had sent as part of an evaluation. This person says it's very good. And then there's someone asked about how can you overcome fatigue and gain strength and energy as quickly as possible. And, I'll just say, see Gary and his team in the integrative clinic, and you're also welcome to come to the Survivorship clinic, where we have a social worker, physical therapist, physician's assistant, and we directly work. Still, we partner with our dietitians, even though we don't have one sitting in the clinic right now.
I'll just add, sometimes it's important to respect what your body's telling you. And sometimes by not respecting it, you actually force yourself down a more darker, deeper hole of fatigue and challenges. Sometimes, that's part of the journey. And then there are different ways to get the energy. And again, come see us and join our yoga classes and join our meditation classes and everything that's available, because that's certainly going to help too. Okay,
maybe one last, I know we're a little over my goal of 1 hour here, but this seems like an important question for you, Lauren. A patient who's a brain cancer survivor. All the chemo has been covered by insurance, but I'm going to be on anti-seizure medication, possibly for life. So does the MAP program help with secondary medicine, if there's insurance issues that come up?
We always look into all types of medications. We just actually got free Eliquis for a patient, oral medication. So it doesn't always have to be infusions or cancer medications. We try to work with any type of medication. A patient will call us and say, I can't afford this medication. I haven't been working. So is there any way that you can help me with my Lipitor? So, even if we can't do it in the hospital, we can always tell them, the Walgreens in this town has a 340B program. And the 340B program will explain to them is when there's a $80 medication, but this specific pharmacy can get it for you for a month for $5. So we always will lead the patient in the right direction of what is best for them, where to go, and how we can help them. Even if it's a good RX card, we can show them how to use that and how they can get their medications a month or 2 months which is cheapest for them. So we always try to help them.
Well, I want to respect everyone's time. I know that our panelists are away from their families for this evening. So thank you all so much for being here. This was really fabulous. What a difficult topic, but really presented with such grace and compassion, and we had great attendance. So we'll sign off now and see you all next week for our final Smilow shares for Cancer Survivors Month.
Thank
Thanks,
you.
Sarah. Thank you all.
Yeah.
Bye-bye.